Hi, my name is Dr. Ashley Fischer, and I'm an outpatient pediatrician practicing in Pekin, Illinois for the past 9 years. Approximately 40% of my patient population involves psychiatric medication management. This is due not only to the low socioeconomic area in which I practice, but also due to the lack of resources and psychiatrists here locally in the area, leading to a necessity to learn this important skill set. So over the last 9 years, I have sought out a multitude of different CME opportunities to allow me to expand my knowledge of pediatric psychiatric care. I've also been involved with a plethora of different organizations, as you can see on my CV, as a Systems of Care grant, and several different work groups locally related to pediatric mental health. I've also been expanding my knowledge through experience. By utilizing the amazing pediatric psychiatrists I have at my disposal, not only through my organization, but through ResourceLink, I've been able to ask questions, run patient scenarios by them, and learn from their expertise. And over time, I've become very comfortable with most outpatient medication regimens for common pediatric psychiatric disorders. Which leads me to now. Recognizing the huge dearth of resources we have in that area, I want to put some of that knowledge to good use. So I have a couple different proposals. The one I think would make the biggest impact is an intensive outpatient program, which I'm going to present to you on here in the next couple of seconds. The other aspect I think would be really useful is helping decrease the psychiatric wait list by providing support to the psychiatrist. Functioning in my head much like an APN would, where I could see follow-ups, patients that are fairly simple, beginning new problems like basic ADHD, depression, or anxiety, with the ability to staff any really complicated patients with a psychiatrist if need be. This would allow the psychiatrist to focus on new intakes, diagnosis, and the much more difficult cases. I really appreciate your time today, and I hope you enjoy this presentation. So I'm hoping that after presenting my proposition for a new model for pediatric mental health care in the outpatient world, that you will all find value in it and want to partner in pursuing this with me. Before we can address the proposition, it is important to take a look at the current state of pediatric mental health care. So 20% of children in Illinois suffer from a mental health issue, and suicide remains the third leading cause of death in the adolescent age group. Readmission to our local pediatric inpatient facilities within 12 months is currently close to 70%. In the time I've been caring for these kids and hearing about their experiences, I've identified 3 barriers to care that I think are leading to these readmission rates. One is access to care. I probably do not need to tell you that this is a huge issue nationwide. Just too many patients and too little providers to provide services. Knowledge of services locally, and then family capacity for compliance. So our current model is a linear one. And so this framework often leads to gaps in ongoing support and reintegration into the community after stabilization. So basically this linear approach is crisis identification. A child is suicidal, is manic, is aggressive, something that leads to the need for an inpatient admission where that child is stabilized and then discharged, usually with a packet of information for parents to perform their own follow-up and their own finding of new services and the different things they need, which oftentimes doesn't get to the base issue that led to the crisis to begin with, which means that we end up all the way back at the start of that linear approach. So how do we break that cycle? This is where this 360 model, I think, could be really beneficial to our community and to these patients. It's a multi-tiered strategy looking at all the different aspects that lead into mental health. So social determinants of health is a bit of a buzzword lately, but for a good reason. So there was really good study of over 10,000 kids that showed that the socioeconomic factors actually are part of what's leading to these mental health outcomes, and that medical care actually only accounts for about 15% of a family's overall well-being, whereas in this linear approach, we're making it 100%. Also, I think important is this Harris poll that showed parents, 32% of them have missed medical appointments because they couldn't pay for it. So how big an issue finances plays in this. 30% say they don't worry about their child's health unless it's an emergency. And 30% are worried they'll run out of food before they get money to buy more. So I think it's really important that we recognize that if we are going to be trying to address this mental health issue, the medical issue at the end of it, we really need to be looking prior to that to what is leading to these statistics. And so here's that 360 approach. And here are all the different ways that I propose that we address it with some sort of intensive outpatient program. Mental health services. As we've talked about before, a lack of therapists and just in general, the time and financial resources for therapists is a huge barrier to care with this pediatric population. Most of the inpatient social workers' time is going to be spent doing different discharge criteria, addressing new inpatient admissions, and this does not leave a lot of time for things like individual therapy. And so many of the children actually get no individual therapy during their inpatient time on the floor. So in this 360 IOP model, I've been describing it to people as basically school for mental health, where it's like a 6-hour day where you're going to get all the things you need to help us get stabilized, but you get to spend the time at home at the end of the day. And in that model, every day the child gets individual therapy, as well as continuous services with the social worker, which is going to allow them to bond with the family unit to better understand how they can support that entire household in this 360 model. Next, we fly down to medical services, the one I obviously have the most experience with. So waitlists to see pediatric psychiatrists here locally in central Illinois are well over a year. And many pediatricians remain uncomfortable in managing those regimens, and this often leads to a lapse in medication. So even once they are on a regimen and discharged on it, that does not mean that they always will continue at outpatient due to this lack of ability to get follow-up and prescriptions. So as part of the IOP, that would actually be on my shoulders, the physician's shoulders, to not only take a look at the regimen, go over any issues with it and help with that medication management, but then also contacting that PCP and talking to them about where their comfort level is and give them multiple different options to get them more comfortable if that's something they want to do. And this would include a coaching program as well as a toolbox, like kind of toolkit that I'm putting together that has several different recorded PowerPoint presentations on outpatient medication management, as well as a Dropbox access to tons of different resources for them to learn more or to use in their practice if they want. And if they are still not super comfortable with it, there will be a coaching program where they can ask questions and send me an email any point in time. And if I don't know the answer, then I will reach out to the pediatric psychiatrist for help in aiding them as well. That is literally exactly what I kind of just talked about. So basically a warm handoff between the provider and the PCP and all those different things to allow for the patient to get that continued management. And then family and social support. So once again, we looked at 15%. That's it. That's all medical care provides for a family's well-being. So how do we get these family and social supports to be better involved? And that's going to be, once again, on that social worker's shoulders, where the team would be more of that 360 approach, the physician talking to the social worker, talking to the therapist, to make sure that we're addressing all the different aspects needed for this mental health 360 model. As a big part of that is the Systems of Care project that I've been working on for the last 3 years with the grant team. And so this is a grant Carl has to basically create a Systems of Care for mental health. And we have leaned into the IRIS system, which is basically a network that allows for social referral to organizations that provide certain services, and it catches the kids at any point in time in where they may be getting seen. So think of it a lot like putting a referral into Epic, except that you can go in and you can search for whichever need the family has, if that is food insecurity, if that is transportation issues, if the parents need mental health resources, if the parents need substance rehab programs, if the family needs help getting a therapist or money for a therapist, any of these types of things, you can actually search in the IRIS system and it comes up with options for you to put a referral in. And then that organization will get the referral and actually contact the family. And that way, this is no longer the onus of the parents and we don't have to worry about compliance issues well, at least not as much, because the organization is going to follow up with the family. And any organization that's involved in the IRIS system can put in these referrals. So even if this is a child at school who is struggling in the mornings and the therapist or the counselor there finds out that they are not eating breakfast because their family doesn't have food, they can go in the system and they can make that referral. This will also help with making more knowledge of the different resources around. There's so many programs, scholarships, support systems that are involved in these different mental health issues that so many pediatricians, so many therapists, so many families just don't know about. And so they aren't able to take advantage of those resources. And by conglomerating them in this model, it's going to allow us to connect them no matter where the knowledge of the person sitting at that, system searching it has, they're going to be able to find all the different resources here locally. I think this is going to be pretty life-changing for our community. And then this is something that it's kind of like on my dream board. So this is something I would eventually like to do, but is to provide opportunities for educational sessions on different things like safety planning, crisis management. I am creating a social media channel called MomMD, where I'm going to be doing a lot of patient education videos, and they're quick to the point, things on behavior management. And these are some other ones I want to do so that we can have better access for our patients to this information and materials. And maybe meet them where they're at instead of requiring them to physically come in for learning. And then obviously socioeconomic factors is a huge one. So we've already talked about how big a part this plays on mental health. And this is once again where that social work and then the comprehensive team of everybody involved is going to address making sure that the economic needs of the family are met, that they are in communication with the school on any sort of factors that can contribute there, getting them in the free lunch program, getting them an IEP or a 504 if that's needed, all the different supports around that are going to allow complete comprehensive support of that child. And this talks a little bit about making sure that we coordinate with the schools. So having a tutor as part of any sort of any outpatient program model like this, I think would be really important because a lot of times when kids are missing school due to mental health issues, they're getting behind. And if they're not getting the support they need to get caught up, mental health is just going to continue to get worse. Bullying is also a huge issue right now, where we're seeing a lot of kids with anxiety, not wanting to go to school, wanting to do homeschooling, which we know through studies is not the best way to address this either. So making sure that part of that 360 model is really addressing that school environment and what different changes we can make there to help support the child. Cross-utilization of services. So this one is only if we had access to an inpatient unit, but I do think that an IOP attached to an inpatient unit definitely makes the most sense because we can then share resources such as like yoga and different things like that. Once again, on my dream board, that we really need to have some sort of framework for the juvenile justice services and how we reintegrate those kids. I think an IOP is a really good way to do that because it allows for, once again, that 360 model. Right now, when these kids are taken out of the juvenile system, they are literally just popped back out into society and expected to be caught up on school, expected to have the social network needed to reintegrate. And I really don't think that's very reasonable, probably leading to the high recidivism rate we see. And then that ongoing monitoring. So in this comprehensive model, that social worker would also perform as a care manager, where keeping files on these families and then following up with them, either through phone calls or even just tracking through the IRIS system, which does allow tracking of those referrals that we can look and see, was the family contacted, was the service provided? And so having that follow-up is going to be a really important part of this model to ensure that we're not losing these children into, the noncompliance of resources and then just catching them again when they're back in the hospital in crisis. I think this is how we help destroy that linear timeline. So the bottom line is that there needs to be integration of medical care, therapy, education, and community services. And that's going to provide a much more effective 360 model and prevent relapse in these kids, at least is the hope. So here's what I bring to the table. So hopefully I've convinced you of my passion about this. So this is something that, like I said, as I've treated these kids, I love
being involved in their lives. I love helping with mental health support. I love the medication management, and I'm passionate about helping all the kids locally here in Central Illinois, not just my patients, but I want to change systems so that we are doing better. We are providing more higher quality of care, and we're supporting these kids in hopefully not being admitted to the hospital. As I said, I'm fairly confident in medication management. Obviously, I'm not a pediatric psychiatrist, and I never pretend to be. So part of this model would be a requirement of some sort of oversight or coaching or ability to talk to pediatric psychiatrists to staff some of the harder cases. In my head, I really see this playing as a PN model. So kind of the same way where I see follow-ups, I can do some of the easier ones, things I do in my outpatient practice as of now on my own. And then if there are more difficult cases, being able to staff them so that we make sure we're doing the right thing by the patients. I'm very enthusiastic about quality improvement. Hopefully that's also come across in how involved I am on my own free time, by the way. This is all volunteer for all the different committees I'm on. Um, how involved I am with these different systems of care projects, these different projects meant to create a better system for everyone and quality improvement for everybody, not just, my office or not just a couple patients. Once again, hopefully I've convinced you of my public speaking abilities, but if not, I am going to eventually have this MomMD channel finally up and running, and you'll get to see some of the videos I make. I also have quite a few recordings of my presentations I give for students, if you're ever curious about that. And same thing with media presence. I'm very comfortable in front of the camera. I think that could bring a lot of good attention to the program and get us a lot of involvement and hopefully a lot of grant funding and interest from different donors. And then advocacy is something I'm obviously very passionate about with all my involvement. And so being able to help get better funding, get better access to resources. I have relationships with multiple senators, multiple of legislative bodies representatives, and I think I could bring a lot to